All right. So we've had some technical difficulties, but now everything should be working. And let me just share the link to this live into our group. And yes, we do have a WhatsApp group. And okay. All right. So basically, what we're going to be doing is we're going to solve some USMLE cases. And I'm not going to start now. Basically, I'm going to start when I'm going to have some viewers. And in the meantime, we're going to discuss some cases or some topics that I feel that are important. So basically, we're going to keep discussing topics until we have, let's say, 15 viewers, and then we're going to go for the cases. 10, 15 viewers. I feel like that's fair. Of course, if you guys have any topics in mind that you would want me to discuss, of course, I'm more than open to discuss those topics. But I've also prepared some topics that I feel that are important and that I want to explain them and discuss them. So unless you have something else that you want to discuss, you can just type in the chat. I'm going to start with some medications and some diseases that we can discuss first. All right. Recovering. Okay. So first, let's discuss the video that we uploaded recently. It's a video about the antiemetic medications, basically medications that would stop you from vomiting. Of course, patients who are taking chemotherapy and patients who are on many different medications are likely to develop nausea and vomiting. So these patients are more likely to vomit, of course, and vomiting is bad for many reasons, especially for sick patients, because they will get dehydrated very quickly and they will have electrolyte disturbances as well. Data not solve that issue. Click presentations. Not sure what do you mean. Let me just go back to the antiemetics and we'll come back to the chat. So the first medication in the antiemetics that we want to discuss is loperamide. Loperamide, of course, is an opioid drug, but just like all opioids are highly addictive. So the trick about loperamide is that it actually has very low blood-brain barrier penetration. So the medication is in the circulation and it will act as any other opioid will, but it does not go to the brain or does not go effectively to the brain. So it doesn't cause the addictive features that we see with other opioids. But just like all opioids, it will slow down the gut. And this is actually a common thing that we see in the practice a lot. Patients who are taking morphine, especially patients on chronic health issues, who are constantly hooked to morphine, they will have slowed gut and they will have constipation. So those patients can be treated with loperamide. They have the same presentation as if they were taking loperamide. So basically, loperamide, like all opioids, will slow down the gut. So we can use this feature with patients who are having diarrhea, who are having fast gut or quick gut movement. So we slow it down with loperamide. Okay. The way that I remember loperamide is loperamide is like kind of saying opioid. I don't know. It kind of makes sense to me. So the other medication is metoclopramide, and this is a dopamine 2 blocker. It promotes the gut motility. And it's a very strong antiemetic medication. Basically, it's just a dopamine blocker, and like most or all dopamine blockers, it will cause symptoms of Parkinsonism, especially with prolonged use. The third medication that we're going to talk about is ondansetron. Ondansetron is a serotonin blocker, serotonin receptor blocker, and it's a very strong antiemetic medication. In fact, this is the medication that we use most of the time in the clinical practice. So we've talked about three main medications that are antiemetics. Loperamide, which is an opioid, it has low blood-brain barrier penetration. We have metoclopramide, which is a dopamine blocker, causes Parkinsonism, especially in prolonged use, and ondansetron, which is a serotonin receptor blocker. So these are the antiemetic medications. There are some laxatives that are also important that you should know about, especially in the exam. And we can divide them into three groups. I have them here on the screen, that's why I keep looking at this area. So the first group is the bulk laxatives. And this is basically stuff that have very high osmolarity. So once they enter the lumen in the small intestine or in the large gut, they will draw water into the intestine. And this includes psyllium and cellulose. Cellulose, of course, because we cannot absorb and digest cellulose effectively, so it will absorb water into the gut. The other group is osmotics, which is just like bulk group, except that it's designed specifically so that it pulls water from the body. This includes magnesium, ethylene glycol, and lactulose. Lactulose, interestingly, actually treats patients who are having cirrhosis with severe features. This is just a side note. Bowel stimulants, like senna, this stimulates the enteric gut and promotes movement. So basically stimulates the nerves in the gut. So we've talked about the antiemetic medications and we've talked about the laxatives. Is there any other topics that you feel that are important that we should cover? I've prepared some topics here, but if you have something else that you want me to cover, sure. All right. So let's talk about Ophthalmia neonatorum, I think it's called. So basically red eyes in newborns. Certain patients, certain newborns, once they're born, they will have red eyes. Some of them will have red eyes immediately after being born. Others will have it days or weeks later. This is quite significant because certain locations, certain red eyes in certain timings indicate certain diagnoses, and we can treat them effectively. And if we don't treat them effectively, they will have consequences. Basically, if the newborn is having red eye immediately after birth until 1 day, so from birth till 24 hours, this is mainly caused by chemical irritation, being exposed to the chemicals in the hospital or wherever they're born, being exposed to the air, and this causes some irritation in the eyes, and they will have red eyes. This is not very red as having like red light red. It's just mildly pinkish. So basically, red eye within 24 hours of life is chemical irritation. That's fine. You don't need to worry about that. But we have another cutoff point. So the first cutoff point is 24 hours. The second cutoff point is 7 days or 1 week. If the newborn is having red eyes within 1 week of being born, this is caused by Neisseria infection. Neisseria, if you remember, it's the gram-negative infection, which is a diplococci. It's the only diplococci that is gram-negative ever. So if you heard Neisseria, remember diplococci gram-negative. So basically, red eye within 7 days of being born is caused by Neisseria infection. And of course, we treat Neisseria by intramuscular ceftriaxone. This is very, very important. Intramuscular ceftriaxone. If the newborn is having red eye more than 7 days after being born, this is likely caused by chlamydia. And it's actually quite remarkable how Neisseria and chlamydia are often associated together. So more than 7 days is caused by chlamydia. We treat chlamydia by oral azithromycin. So Neisseria, less than 7 days, intramuscular ceftriaxone. More than 7 days, chlamydia, oral azithromycin, or any other macrolides. We normally just start with azithromycin because you only have to take it 3 times. The other scenario is if the newborn had the red eye later on, let's say 20 days or more. This is likely a viral infection. And the most common culprit is herpes virus, and so we use acyclovir, intravascular acyclovir. So these are the main causes of red eyes in the newborn. The whole spectrum is called Ophthalmia neonatorum, I think it's called like that. And this is how we treat them, and these are the cutoff points: 1 day, 7 days, and 20 days or more. All right. Actually, it's quite. Speaking of chlamydia and Neisseria, these infections are commonly associated together. So patients who are having chlamydia infection are very likely to have concurrent Neisseria infection, chlamydia and Neisseria together. And these both are actually STDs, sexually transmitted diseases. So patients who come to the clinic with Neisseria infection or chlamydia infection, we treat them with both. Most of the time, we just straight away treat them with both because this is likely a concurrent infection. Or it's very likely that they will have the other infection as well. So ceftriaxone is always the treatment for Neisseria, and azithromycin is always the treatment for chlamydia. So these are the topics that I wanted to cover before we go to the cases. Again, if you want me to cover any other topics before we start the cases, we can do that. I have some topics here that I feel were maybe interesting, and we should cover them. So, all right. If you don't have nothing else to cover, we can start with the cases now. So, the first case, this is actually a case that I covered in the second channel, the USMLE cases, but I'm going to start with a different approach so we can basically not spoil it for people who haven't watched the video yet. So this is a researcher who is conducting an experiment to determine the life cycle of a certain virus. She concluded that the virus genome changes depending on the stage of the infection. The virus starts with the RNA genome, which transforms into double-stranded DNA genome, and then back to an RNA genome. This life cycle is identical to which of the following viruses? And it lists adenovirus, herpes viruses, HIV, and influenza virus. So basically the question is asking a researcher, this is a common scenario, they will tell you a researcher is doing some research or something like that, or whenever you hear a researcher or a publisher or a school teacher or something, they're doing an experiment, a research, a trial, whatever, they're going to be asking about genetics, or 99% of the time they're going to be asking about genetics. So you can kind of know the topics from there. And indeed, we do see this question following up with genetic question. So the virus starts with an RNA and then transforms into double-stranded DNA and then goes back to being RNA. So basically, the viral genome itself, we can conclude from this scenario that the viral genome itself is an RNA, and then it becomes double-stranded DNA, which is just like our DNA, and then goes back to an RNA. It makes sense that this virus is likely a retrovirus, right? Because it changed the RNA itself to a double-stranded DNA and then back to an RNA. This is a feature of all retroviruses. Retroviruses like hepatitis B virus will use an enzyme called reverse transcriptase, which basically reverses the RNA of the virus into double-stranded DNA, which is identical to our DNA, to be able to integrate this double-stranded DNA into our own genome and then goes back to make more viruses. And other retroviruses that we can think of are, of course, HIV. HIV is the most known retrovirus, and indeed it is one of the options. So HIV virus has the virus itself. It's basically a capsid with protein and an envelope, and inside there is the RNA genome and there is the reverse transcriptase enzyme. There are 2 copies of reverse transcriptase enzyme in every HIV molecule or in every HIV virus. Once the virus infects our cells, it will use the reverse transcriptase to reverse the RNA of the HIV virus into double-stranded DNA, and this will be integrated into our own host cell, which will make more RNA viruses. So RNA, double-stranded DNA, and RNA again. There are some other cases that you might see in the exam. So other examples include. So there are other examples that you might see, which include, for example, a double-stranded DNA. The virus itself is double-stranded DNA, and then it became double-stranded DNA again, and then once more double-stranded DNA. So DNA, DNA, DNA. And this is fairly simple. It's basically asking about any DNA virus or any double-stranded DNA virus, which I believe is all of them. So if this is the case, just think of any DNA virus. The most common is going to be herpes, of course, herpes viruses. So double-stranded DNA, double-stranded DNA, and double-stranded DNA. Other cases include, of course, if it was RNA, 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 this includes the RNA viruses, like polio, influenza, measles, and rabies. These are the most common. These are not retroviruses, so they will stay RNA for the whole 3 stages. Speaking of herpes viruses, I feel like we should actually cover the herpes group, because these are very, very important and they're commonly tested. Right. So the HIV, I have the references on this side, so I'm going to be looking at this side when I'm reading the references. So the HIV virus is subdivided into 8 groups, or 8 HIV viruses from 1 to 8. Number 1 is called the herpes simplex 1. Number 2 is called the herpes simplex 2. Or any of these viruses can be referred to by the common name or by the simple name, by herpes number yada yada. So herpes number 1 is herpes simplex 1. Number 2 is herpes simplex 2. Number 3 is varicella zoster virus. Number 4 is Epstein-Barr virus. Number 5 is cytomegalovirus. Number 6, I think, is called, if I'm not mistaken, number 6, number 7, and number 8 are just called herpes number 6, 7, and 8. So they don't have a specific name because they're not as common. And they're weak. They require the host to be immunocompromised to have any noticeable symptoms. So starting with the herpes simplex number 1, we'll cover the whole group, the whole 8 classes. Herpes simplex 1 and 2 are the most common. Number 4 is also kind of common, but 1 and 2 are very common. So herpes simplex number 1, it's transmitted by secretions, so salivary secretions and respiratory secretions. So basically the mouth. Think of number 1, the first thing that comes into your mouth is herpes number 1 because it comes out of your mouth literally. So saliva and respiratory secretions. It causes gingivitis, I think it's called. So it's basically inflammation around the corners of the mouth. It causes keratoconjunctivitis as well in the eyes. Herpes labialis is also known as herpes labialis. And it also causes the white low in the fingers of the hand. These are white spots that are very distinctive for herpes. So these are other features are not as important. So the things that you need to know about herpes type 1 is that it causes gingivostomatitis, the basic inflammation around the mouth, the keratoconjunctivitis around the eyes, the white low in the hands. In very compromised patients who are having the worst luck, it will cause some encephalitis and brain symptoms as well. So herpes number 1, not as severe symptoms, mainly in the face, and it starts from the face as well because herpes number 1 goes from the mouth. All right. Herpes number 2 is sexually transmitted, and this is what we refer to when we say sexually transmitted diseases. We're referring to herpes number 2. So basically it causes genital herpes. That's all you need to know. It's treated by cyclovir and causes genital herpes. These are the important notes. Herpes type 3. Now, herpes type 3 is quite interesting because it's almost completely eradicated nowadays, and it's getting less and less cases, which is very good. So it's also known as varicella-zoster virus. The varicella and zoster, these are different stages of the virus itself. Varicella is the virus itself. Zoster is when it causes shingles in the hand or whatever skin dermatome. Now, a very striking feature for herpes number 3, which is varicella-zoster, is once the infection starts anywhere in the body, it will infect only one dermatome of the body. So, for example, and most common in the chest, actually, chest area. So, herpes type 3 will infect the skin, or whatever area that is, and then it will cause redness or some burning sensation in the area that it infects, and it will not have any other skin findings at that time. But if you treat the infection during this time when it doesn't have any skin findings, the patient is very unlikely to develop later on more complications as the time goes by. If you've heard of herpes neuralgia, it refers to varicella-zoster virus infection that has not been treated by acyclovir in time. So if you treat it in time, you will not have any complications. So varicella-zoster virus infects only a single dermatome. If you treat it early, you will not have symptoms. Okay. Type 4 is, of course, Epstein-Barr virus, which was known before as the kissing virus, because teenagers would normally infect each other by kissing patients who are having Epstein-Barr virus. Of course, infamously, it causes mononucleosis, which is an enormously important piece of information that you need to know for the exam. You will almost definitely be asked about mononucleosis or mononucleosis-like illness. It's very easy, it's very straightforward, just know the symptoms and you're pretty much there. Herpes type 4 and type 5 cause the mononucleosis and mononucleosis-like illness respectively. So type 4 causes mononucleosis, which is basically from the name. Imagine if somebody says leukocytosis, it means that you have a lot of leukocytes. Lymphocytosis means that you have a lot of lymphocytes. And when they say mononucleosis, you're going to have a lot of monocytes. And this is basically what we mean by by mononucleosis. Now, the Epstein-Barr virus, which is herpes type 4, once it causes the mononucleosis symptoms, basically increasing the number of monocytes, there's a specific test that we can test that looks for this, the Epstein-Barr virus, and this is called the monospot test. If the monospot test is positive, this is Epstein-Barr virus. If it's negative, this is mononucleosis-like illness, which is cytomegalovirus. All right. Herpes 6 and 7, like we said, they're combined together, and they cause the slapped cheek syndrome. Basically, children who cheeks feel very red as if somebody had slapped them, and that's why we call it the slapped cheek syndrome. The scientific name is Rosella infantum, red cheeks of infants. Rosella infantum, or redness of infants. Herpes type 8 causes Kaposi sarcoma, just like HIV virus in immunocompromised patients. So these are the notes for the for the herpes viruses. And well, let's cover another case. Let me see. All right, this is an interesting case. So the case goes, a patient is complaining of a new rash in her cheeks and nose. The rash is worse when she's exposed to the sun. She's also complaining of fatigue, vague pain all over, and she recalls starting a new medication recently, but she forgot the name of the medication. So, to sum up, a patient just started a new medication, and now she's complaining of rash in her cheek and nose, and the rash is worse when she's exposed to the sun. She's also fatigued and tired, and she has vague pain. These symptoms, as you like, if you can look at them critically, they're all vague and widespread. It's pain all over, vague pain, skin rash. So we think of something systemic and not localized. So you can rule out infections, you can rule out skin syndromes because they wouldn't cause the pain and the vague fatigue. And a very important note is that she started a new medication recently. Now, these symptoms, if we can look at it, especially the rash around the cheek and nose, is very characteristic of lupus or systemic lupus erythematosus. And the fact that she started a new medication recently, this will put the first diagnosis in my list, is drug-induced lupus. So the question asks, which of the following medications is likely used? And I'll list many different medications, but the two medications that we know that can cause lupus are hydralazine, and I think it's called procalamide. Procalamide is the first generation or first class of the antiarrhythmic drugs. So class A antiarrhythmic drugs, we have procalamide, I think it's called, and we have hydralazine. These two medications can cause drug-induced lupus. These patients, if they did any lab tests, first of all, they will have an identical symptoms of lupus, and if they did lab tests, they will see increased lupus markers like ANA and anti-double-stranded DNA. But characteristically, they will have an anti-histone antibody, which is very characteristic for drug-induced lupus, and we do not see it in normal lupus. And this is the separating feature, along with the history, of course. And the question can sometimes just throw things in there, saying, for example, that the patient's cousin or her sister or mother has lupus at the same age that she was. This is just a distractor trying to push you away from the main diagnosis. So, drug-induced lupus, think of symptoms that we see in lupus. Medications, we know that hydralazine and procalamide can cause drug-induced lupus, and the very specific test, which is anti-histone antibodies. So this is the second case. Let's look at one more case. Then I think we'll call it a day. Okay, this is interesting. So basically we have a 53-year-old male complaining of pain in his leg when he walks for short distances. However, when he stops walking, the pain persists. However, he recalls feeling better when he goes shopping and he leans forward against the shopping cart. Which of the following would be seen in this patient? And it lists worsening pain when walking downhill, worsening pain when walking uphill, long history of coronary artery disease, or negative straight leg rise test. So the patient is having pain in his legs when he walks, and the pain persists when he stops walking. And it recalls a very important piece of information. It says that the patient feels better when he goes shopping and he leans forward against the shopping cart. So leaning forward makes the pain better. And stopping does not alleviate the pain. My cat is just making sounds for about that. So what would make think of things that would cause the patient to have pain in his leg, and the pain would be better if he leans forward. The first thing that would come to my mind is either claudication or pseudo-claudication, because these are the most common causes of pain when walking. Claudication is caused by narrowing of the blood vessels in the legs, and pseudo-claudication is caused by neural tests or nerve compression. So the question didn't ask about claudication or pseudo-claudication, it simply asked about other symptoms. So we need to know the details of these two. It's not DVT because DVT will cause pain mostly in the thighs, not in the legs. It does cause pain in the legs sometimes, but mostly in the thighs, as the femoral artery is the most femoral vein, sorry, is the most common location. But still, DVT would not cause pain in both legs, and it has no relation with the leaning forward. Plus, DVT patients will feel better when they stop walking, and the history would likely mention something of leg swelling, something like that, redness. So, my diagnosis, whenever I hear pain in the legs when walking, the first thing that comes to my mind is claudication or pseudo-claudication, like we said. But with this scenario, with this giving scenario, especially saying that the pain persists when he walks. Actually, I forgot which one this is, but pain persists when he walks. We only see this with neural compression, with pseudo-claudication. So I think this is the diagnosis. The diagnosis is pseudo-claudication. It is pseudo-claudication, actually. And the question asks, which of the following is likely seen in this patient? Pain when walking uphill, pain when walking downhill, long history of coronary artery disease, and negative straight-legged rise test. Of course, neural compression. You have to imagine the anatomy of the spine and the anatomy of the legs. When neural compression causes pseudo-claudication, such as we see in this patient, the spine itself, when he's walking downhill, is worse. Okay, so basically, the spine itself will lean backward when somebody's walking downhill. Basically, because you're walking downhill, you're trying to make the center of your gravity backward so you don't fall forward. So you lean backward, and this stretches the spine. And actually, this stretches the vertebrae themselves, but compresses the spinal cord. And this is why they feel worse pain when walking downhill. And this is the answer. They feel worse pain when walking downhill. And this is also why the patient feels better when he leans forward. Because when you lean forward, you will compress the vertebrae in the front, but you will basically relieve the compression in the spine. So the patient will feel better when they lean forward as they push the grocery cart. So this is pseudo-claudication. If it was claudication, we will see pain in both legs that feels better when the patient stops walking. Because claudication, the main pathology or pathophysiology behind pseudo-claudication is compression of the spine, and the nerve will stay compressed when the patient walks or stops walking. Because basically when you're standing, you're compressing the spinal cord. But with claudication itself, which is a cardiovascular problem, the muscle will demand a lot of blood when somebody's walking. But because there's a narrowing of the vessel, the narrowing will persist whether you're standing or walking. But the muscle will demand less blood when you stop walking. So patients with claudication, the cardiovascular problem, they will have no pain when they stop walking, they will have pain when they continue walking. Pseudo-claudication, the neural problem, they will have pain when walking and they will have pain when they stop walking. So I think that's all that we need to talk about claudication. So the claudication, this basically covers all the important stuff. How does stretching the spine cause leg pain? Well, the spinal cord basically runs within the spinal cord, and then the nerves leave the spine itself, going to the legs. So the compression goes backward and compresses either the spine itself in the L4, L5 to S1. This is the most commonly compressed area. And this is the area where the nerves that feed the legs muscles go. So if you compress this area, they will have pain in both of your legs. This is one scenario. The other scenario is compression of either nerve that leaves the spinal cord. And this can be very tricky to diagnose because pseudo-claudication commonly affects both nerves, not one of them. But it can be either nerve, of course. Sciatic nerve, that's a different scenario. Sciatic nerve is mainly caused by disc herniation. So basically the spinal cord, we said that the discs are in the front, and once the disc herniates, the disc is basically composed of hard exterior and a soft gel inside. Once the gel protrudes outward and compresses the sciatic nerve, the patient will have sciatica or sciatic nerve symptoms. And this is actually a distractor that was thrown in the question. One of the answers was negative straight leg rise test, or STL. The straight leg rise test is only ever significant for sciatica. So whether it be positive or negative in this scenario, it has no meaning at all. It's just a distractor. All right. So that's all about claudication and pseudo-claudication. Any other question about this scenario? I think we'll do one more before we call it a day. If you have any topics that you want me to cover, I'm more than glad to do so. But if you don't, I'm just going to pick one more case and we'll go through it. Okay. This is a very sneaky kind of case. It's not okay. So basically, it's very understandable if people don't get the answer at first hand, because it's kind of very detailed step one question. And these questions, I like these questions so much because these are the questions that will determine the basically high percentage people or high percentage test takers from others, because it requires a really detailed level of knowledge of certain diseases. So the question goes, we have a 6-year-old girl who came to the clinic with her mother. The mother says the child hasn't been acting normal for the past couple of months. She has been very irritable and constantly complaining of abdominal pain. There is also loss of appetite and weight loss. She is vitally stable at the moment, and X-ray shows white lines in the bones metaphyses. CBC showed microcytic hypochromic anemia. Okay. So it's one of the two cases. I think most people are going to be like, oh, this is exactly the diagnosis that I'm thinking of, or thrown off because of the symptoms are kind of here and there. So if we revise it, a 6-year-old girl, so pediatric, came with her mother, yada yada, and the mother says the patient is acting irritable. So this kind of throws in the psychiatry distraction, because most of the time, or not most of the time, but a lot of times the mothers would make up scenarios or make up symptoms in the exams. So whenever in the exam you hear the patient's relative or the patient's brother, mother, whatever friend is saying that they have these kind of symptoms, it's kind of sketchy because you need to hear the symptoms from the patient themselves. But anyway, it says the mother says that the patient has been acting irritable and constantly complaining of abdominal pain. So two very vague symptoms. But she's also having loss of appetite and weight loss. This kind of corroborates the mother's narrative. X-ray showed white lines in the metaphyses of bones, and CBC showed microcytic hypochromic anemia. Anyway, the first thing that would come to my mind when reading this question is, of course, celiac disease. Celiac disease, I would want to read, like, to convince me that this is celiac disease, I need to see something, of course, in an older patient, and significant weight loss. It's actually very close to celiac disease. Yeah, you're right. You're right. But I wouldn't see microcytic hypochromic anemia unless they have iron deficiency anemia. But the question asks, which of the following enzymes will be inhibited in this patient? And it lists ALA dehydratase, lactate dehydrogenase, thiamine oxidase, pyruvate dehydrogenase. So it's very biochemistry detailed. And you need to know the disease, you need to know a very strong background about the disease. The first thing that would come to my mind when saying microcytic hypochromic anemia, this will basically give you the disease right away, give you the diagnosis, because it gave you a very specific finding in the CBC, which is microcytic hypochromic anemia. We only have 4 diseases that can cause microcytic hypochromic anemia. These are alpha thalassemia, beta thalassemia, lead poisoning, and sideroblastic anemia. These are the ones that I remember. I think maybe there's one more. So, and of this scenario, the one that applies is lead poisoning. So the symptoms, because lead poisoning starts very vaguely and it doesn't have any striking symptoms right away. It will cause abdominal pain, it will cause irritability, in adults it can cause depression, in elderly it can cause dementia. So it's very vague, it wouldn't just jump at you right away. Lead poisoning. And it's also very uncommon nowadays. But the striking or the hallmark of the disease is white lines in the metaphyses of bones. In every test that you're going to see in the exam, there's going to be one hallmark. There's going to be this one striking feature that gives away the disease right away. And if they don't have this hallmark, you will definitely have an exclusion of other options. So you're going to have one of other. In this case, lead poisoning is the answer, because abdominal pain, irritability, lung symptoms, microcytic hypochromic anemia, and white lines, which are called actually the lead white lines. So 5 features that are very specific and very consistent with lead poisoning. But the question asks about, it doesn't ask you about the lead poisoning, the diagnosis itself. It knows that you should know the diagnosis. It asks you about another detail of the diagnosis, which of the following enzymes is inhibited by lead. And this is a common scenario that you're going to see in the exam often. The exam will constantly ask you, I think it was something like 70% of the exam is a three-way question. They call this three-way question or three-point question. Basically, the question will ask you something and it will require you to mention or to recall 3 points or 3 ways. In this scenario, I think it's a two-way question, because the first point is that you have to know the diagnosis, which is lead poisoning. The second point is that you have to know which enzyme is inhibited by lead. So it's a 2-point question. I think most of the exam was a 3-point question. About 20% was two-point question, and 10% or 15% was 10-point question. Something like that. I'm not entirely sure. I forgot. But this is basically the idea of the exam. It's not gonna ask you about something straight away. It's gonna ask you about something, about the other thing that you might know about the condition that you have to know. So it's a big loophole. Lead poisoning, if you remember, lead inhibits 2 enzymes. The first is ALA dehydratase. The second one is, I think it's called ferrochelatase or something like that. Yeah, ferrochelatase. So lead poisoning inhibits both ferrochelatase and ALA dehydratase. So we concluded by the symptoms that the diagnosis is lead poisoning. We know that it inhibits ferrochelatase and ALA dehydratase. Speaking of lead poisoning, the initial test that you should do for lead poisoning, ferrochelatase basically. So the initial test that you should do if you suspect the patient to have, this is a step 2 question, it's not a step 1. They will not ask you about the test for lead poisoning. But if you want to know it in general, the first test that you should do is capillary test. It's just a small cat that you prick the finger. It will take some sample of blood. It will detect the levels of lead. If the sample shows positive lead levels, then you're going to take a blood sample, a venous blood sample, and send it to the lab for official lead levels. So the initial test that you should start with if you suspect lead poisoning is the capillary test. The confirmatory test is the most accurate test is the lead venous blood sampling. So it just goes more about the details and stuff. I think we covered everything here. All right. So that's all about lead poisoning. If you guys have any other questions, I think that pretty much sums today's live footage. Probably going to be doing some more in the future, not entirely sure. Just solving cases and explaining topics. If you have any other topic that you need me to cover before we call it off, more than happy to. So just give it a couple of seconds to see if somebody wants to write something. Thank you. I think I will. So I think all of these topics will take longer time, so we'll just save it for another day. All right. So this has been me, I guess, and I'll see you guys later.